Edie.
Thank you. Anyone opposed to approving the agenda? Hearing none, I will consider that approved. Thank you. Any disclosure of pecuniary interest this morning? Seeing or hearing none. The adoption of the minutes from Friday, July the 24th, 2020. I need a mover and seconder to get them on the floor.
Patterson.
Milne.
Thank you. Were there any errors, omissions, or discussions from those minutes? Hearing none, I will take that as approved. Thank you. Correspondence.
So, Mr. Chair, this is Dr. Era. As we did for the past four meetings, we enclose all the details and we are open for a question in interest of time and efficiency.
Okay, so get a mover and seconder to get the correspondence on the table. Mover.
Laporte.
Lori. Seconder.
Edie.
And thank you. Any discussions on any of the correspondence as presented this morning?
I was just noticing something. The opioid kind of crisis. Let me see, what item was that? Number 5, maybe. I'd have to.
It's in the news release 6.
I think the news releases.
Oh, that's the news releases. Yeah, sorry, I've got the wrong thing.
No, one item.
But you had the number right. It is 5.
Okay, all right. I'll wait till the news release.
Mr. Chair, it's Sue.
Oh,
Could Dr. Era expand on the last item in the correspondence about assistance to Windsor Essex Health Unit? Just sounds like a nice letter that the health unit received.
Certainly, through you, Chair, if I may, the Windsor Health Unit sent a letter of appreciation of our assistance to the health unit in Windsor in managing the outbreaks. We had updated the board before that under the mutual agreement among health units in the Southwest, we have the obligation, if we can, to support other health units when they are in need. And Windsor Health Unit had a situation that was complex related to outbreaks in seasonal farm workers. We have reviewed our resources and the situation at hand, and we were able to provide them with a couple of staff members to support them in contact tracing, contact management, and outbreak management. And that required work in the background with the corporate services, the IT, to set up the access. So our staff was working from in-house here and supporting Windsor Health Unit for a period of time. And we received that letter after Windsor moved to the 3rd stage recently. And if I may explain, we received the letter a couple of days ago after we sent the agenda out, and that's why we added it as amendment in the agenda.
Thank you.
Any other comments?
Number 4, the Brockton one.
Item 3 needs disposition.
Sorry.
Number 3 was either endorse or receive.
Right. Number 3 is endorse or receive the letter to the minister.
Did we not do that April the 24th, I believe, just going off the top of my head, that we've already endorsed that?
Only received.
We received before.
Okay, sorry, I misunderstood that. What's the board's thoughts? Do you want to receive or endorse that item? I'm hearing receive for now, folks.
Yeah.
Okay. Any other questions or comments? I guess my comment would be thanks, Drew, for all the hard work you're doing in communicating with the public. It's a monumental task, I'm sure, from day to day with all the inquiries you're receiving. So I just want to thank you for that, because it's well written, and I sure appreciate the detail that goes in there, because I've had that comment made to me about the communications coming out of the Grey Bruce Health Unit is second to none. So I want to thank you for that.
I appreciate that. Thank you.
If there are no other discussions, that we will look at this as approved. Okay, thank you. Sue, can you scroll up?
Sorry.
Sorry about that, putting you on the spot. Okay, next up is the Medical Officer of Health update, Dr. Era. The floor is yours.
Thank you, Mr. Chair. I'm just getting the technology. Oh, sorry. Would you be able to put it down? No block. So, safe reopening of schools in Grey and Bruce, that's the item that the team has been working on. Different teams have been working on for the past few weeks and will continue to do so. The objectives of this presentation is to provide better understanding of the safe reopening as we go into it, and specifically reopening schools, brief review of the HAPL legal framework around managing outbreaks and suspect outbreaks in schools, and collaboration between the Grey Bruce Health Unit and the school sector, whether it's the big district schools or the smaller private schools, and different types of educational institutions in Grey and Bruce. You've seen this slide before. It's related to the underlying principle in reopening in general and in school reopening. And the goal is to minimize COVID impact and the impact from measures to respond to COVID. And both of them are equally important. It wouldn't be a success at the end of the year if we have zero disease in schools, but we have mental health issues and depression in our kids, and hopefully not the severe complications of these diseases, whether it could be suicide or long-term inability to be productive in the society. Achieving herd immunity, again, is the preferable through vaccine, is the ultimate solution for this situation. And you've seen these as well. There are different impacts. Economic impact, again, in schools, it might not be straightforward. However, indirectly, there could be significant impact to health of our kids and our families and our communities in the long run if schools are not reopened successfully. And one concrete scenario, if you can appreciate a family of two parents and a couple kids, and if one of the two parents cannot keep their job to stay home with the kids, the loss of income for a year or two and the inability to go back to work in the same level the person was for 2 more years or so, 4 or 5 years of lower income or loss of income would be detrimental to the health and the well-being of the whole family and the kids in the long run. So again, opening schools is not something a want, it is rather a need for the whole community and society. Examples of successful school reopening: New Zealand, Taiwan, Norway, Denmark, even Sweden, after being sobered with the fact that uncontrolled outbreaks are not the best option. All of them managed to open schools for the past short period of time with 0 cases. And that was some of them in the springtime. Some of these countries have schools during the summer. So that's 0 cases in schools, and that's a whole country. So again, if you look at other ones that had close to success, Netherlands, 6 cases in the whole country. New South Wales in Australia had 18 cases. And here is just a side note that there has been over 850 investigations for these 18 cases. that revealed only 2 more cases. So again, that's how conservative these investigation would be. And we have very similar protocols here that even for the finding 1 or 2 cases, we will go the extra mile. The examples of less than optimal school reopening, Victoria State was a wake-up call to Australia that the virus is not gone. And there were around 150 cases recently in schools. Israel has been the extreme example with around 300 cases. They had to close over 100 schools and over 13,000 quarantined. If you compare the social factors and the robustness of public health systems between these different scenarios, I don't expect we're going to be in the high end. I rather expect we're going to be in Canada in close to the low end. In Grey Bruce, we would be in even a relatively better position. So it is manageable. It is not unmanageable. Legal, certainly.
Go ahead, Brian.
Dr. Era, if I might, can I ask a question, Mr. Chair?
Yes, sir.
Thank you. Dr. Era, any early indications of what the main difference between the optimal situation and the 2 last cases there where there's a lot of outbreaks?
It's a really good question. I don't profess to be the expert in comparing countries, and I didn't, have the luxury of time to review it. I follow these outcomes just to get a closer look. To get the general picture look. In general, when these comparison happens, take place, it would be based on the social aspects, on the technical aspects, the legal aspects, and the healthcare system aspect of it. And if I may elaborate there, the social aspect, the number of individuals in a family. In Canada, we have usually 1 generation, maximum 2, and with low number of kids. Australia would be the same. Many European countries would be the same. In Israel, you would find the 2 or 3 generations in 1 home. The amount of space for the household is another factor related to crowding. The robustness of public health system and the healthcare system. Israel has a really good healthcare system. I don't profess to know exactly if they have the same level in public health. Australia would have very much similar robust public health system like us, Taiwan, New Zealand as well. And that's, from shooting from the hip, so to speak. I can say we will be in the first category, not in the other categories. And I can elaborate a bit more on the factors. However, I have not applied these analyses to compare these countries, Councillor.
Thank you.
Legal framework for managing outbreaks. This is if we go behind the scene to see how we operate in public health, this is the foundation for anything we do. We go to the legal and scientific frameworks. And in this case, it's the Health Promotion Protection Act. The Section 22 is duty of school principal to report disease, whether knowing about case or knowing about symptoms, potential case. So that's one layer of redundancy in the reporting. We receive from the lab the confirmed diagnosis, definitely. So we also receive it from healthcare providers. There is obligation legally to let us know. Section 29 is related to other facilities. Although it's not in schools, any outbreak in the community, whether it's a long-term care or in the community at large or schools, would affect each other. So we are able to see the whole picture, as you all know. Order Section 22 is one of the very effective tools that we use in public health. And it's a tool that could entail asking a person to be tested or to provide test results or take a treatment. In this case, again, in all cases, we go with the least intrusive measure. We don't use these sections and orders quite frequently. And there are penalties for obstruction and penalties for not following direction during the investigations that we run. So this is section 22. I explained that's part of the legal mandate for reporting. And section 22, again, I mentioned these before. I put them here just in case there are questions. We can go back to them. The penalties for a corporation could be up to 25,000 per day for non-compliance. For individuals, could be up to 5,000. And that really allows us to, under the mandate of the Act and the mandate of public health, to exercise the investigations as the leading agency in the endeavor. Case management, contact management, outbreak management, that was our meeting last time. We had detailed description of these tools and protocols. So over the legal framework, we go to the technical framework and the scientific, and those are very robust protocols, and they have served us really well in our area, and they have many aspects to what they require in complexity and to achieve their goal. From the scientific framework also, and the principles of transmission and the factors in transmission, you would see these three principles that still stand in any scenario or in any planning to a reopening of an organization, and they would still apply in our personal life. Any person of us, for ourselves, our family, our community, if we observe the number of people in the activity we're in, the less people, the better, the bigger space, the less risk. The time window, the less time window of interaction, definitely the less risk. And one clear example, I get the question quite often, and it's worth mentioning here so people can hear it from the public if they're later listening to this, is would passing somebody on a sidewalk be a risk? There is always a risk. There's not going to be a risk, zero risk. However, it's negligible just because of the time window and the number of people interacting is two people passing. The ability to modify is another factor in planning. So we look at every angle. Our team looks at every angle from reopening plan for a school in this case or any organization, and we apply these principles. And this is, again, not a new slide, rather it applies in all settings. Physical distancing, the 2 meters or more, is king. It trumps every other measure for reducing transmission in the hierarchy of control, according to the Johns Hopkins. Engineering controls, administrative policies, and PPE using masks. Although the least effective, it's still around 10% efficacy, and it's an added layer to all these things, especially if the other ones are not feasible or practical. So we go to the last section of this presentation: collaboration between public health and schools. And this is not new. It's part of the mandate of public health to work with schools to improve the health in schools and to protect the whole health in case of infectious disease scenario or outbreak. And this item, the one in the middle, number 3, we have streamlined all the services that we provide in schools through one program, School Health. And we would be delivering any service through a coordination of that program. So whether it's vaccine services, infectious disease and COVID team services, dental services, and others, if we have one contact with the school, that will be the most efficient. And this change has started planning. We started planning for it during this summer and has been working very well. Regular meetings, communication is key in emergencies. So we started those communications weeks ago with all schools. We have meetings for all schools in Grey Bruce, and with another meeting with the district schools, just because of the different need these bigger organizations have. And we have scheduled town halls. We started one of them. We sent a letter to parents, and this is just the start of a series of communication that will be on every 2 weeks. The second town hall will be after 3 weeks from the school reopening, the last week of September. Then it will be on every 2 weeks basis. Sharing information with schools, as you would appreciate, with the changes of emergency and the epidemiology, the guidelines will change with the different input points from different stakeholders. The guidelines will change, and many people seem, to be wondering why the regulations and the guidelines that are coming from the province is ever evolving. That's the norm, and that's the way it should be, and that there is better practice. That's not something that we should be anxious about, rather endorse and support, and stay engaged and concerned to be informed, stay informed and engaged in applying them. School Public Health Nurse Initiative, it's something that the ministry announced about 3 weeks ago. We received a letter of funding for 6 public health nurses, extra 6 public health nurses for the Health Unit 500 for all Ontario. We received it about less than 2 weeks ago, and writing. We completed recruitment, and only, this actually should be 6. It was completed 2 days ago when we sent the package. It was 5, and the number 6 is being recruited. Now we can recruited all 6 of them. And truly, this is kudos to the teams around the table, the corporate, the management team, to predict, to calculate the projected need of the organization. So we started this recruitment, or the idea of it, about 3-4 months ago, I would say. Even in general, planning for the future started since March, since the emergency started. But for school reopening, I feel very proud that the team can calculate that far in the future, and our estimate was very close to the ministry's estimate. So the funding will be for 2 years for these 6 positions. And although we recruited new individuals, our plan is to send to the schools the seasoned nurses, and the new recruits will be in-house to learn more about the process and the protocols until they become experts in doing the roles that they will be doing. And it's worth mentioning, although we have, like, the 6 positions are the coordinator. Each one of them would be coordinator for 6 to 9 schools. So they will attend to these schools, and they will have all these teams behind them. So it's not just one individual serving in a school, rather it's a group of teams.
Question, Mr. Chair.
Yep, go ahead, Brian.
Thank you, Dr. Era. I'm just wondering, the 6, excuse me, the 6 nurses that have been recruited, are they new to the area, or like have they been brought? Are they going to come in from outside the region, or are they nurses that were working in the region currently?
They are recruited locally. I'm not sure specifically if some of them have moved here recently for this job or not, but in general, the recruitment happened locally. The direction from the ministry is to recruit, not to provide us with the individuals.
Okay, my concern is that, 500 new public health nurses for Ontario is wonderful, but are we just moving shells on the table around the province? Are we actually creating work for other organizations that I don't want to use the word poaching, but are we moving nurses from other organizations within the region and causing them grief?
That's a good point. I can look back and see exactly whether these new recruits are new graduates or people who worked in different organizations. In general, public health had limited number of resources. So having 500, even if they move from the hospital setting or from family primary care setting to public health, I still think it's a very appropriate investment. Just because, for example, we had 3 school nurses, public health nurses, and that's, would do if you're managing non-emergency, but when you go up to that level, and it will be optimal to continue to have that number for the long term. So in short, even if it moved from another organization locally, I still see the benefit in raising the ability of public health to deliver its mandates.
Okay, thank you.
So the role of public health, as you've seen this slide again before, the last one is the most important: communication. And we have done something early on in emergency that has worked very well, continue to work very well. And it was our plan in the long term for 2 to 3 years to move to this scenario. In the emergency, there is always the need and the opportunity to move things faster. What we did is the health promotion team, a good part of them during the emergency, would not be able to do their job to go to schools because schools are closed, or to go to other partners, since most of these functions have stopped. So we channeled them to support communication. So Drew has been spearheading a group of people, and we have another manager also, the health promotion manager, Ian Reich, has been instrumental. So we have a group of health promoter and people who didn't work in communication per se, supporting communication and sending these messages. And again, your comment, Mr. Chair, has been right on the money. The amount of communication and the efficacy of it has been paramount. We put up the COVID section. We renewed it all in 2 weeks. It's a job that usually takes a few months. In 2 weeks, the team was burning the candle at both ends to ensure it's there. And Drew's leadership in this endeavor has been indispensable. The other roles that public health does, again, as I mentioned before, contact management, supporting the different partners, and reviewing plans. And we still, until this point, actually continue to review plan for reopening for some organizations. And these are the variables that we still look at: testing capacity, system capacity, and virus spread. And each one of these categories is a very long set of indicators that we keep an eye on, and we will be ready during the school reopening to detect early upticks and try to predict what the next step would be. Again, similar to other organization investigations, if there is a case in a school, these are the two final slides. I mentioned getting too close, but I had added a couple of them here. If there is a case in a school, again, we've got this covered. This slide was written for the school and the parents. And we have been successful. If you go to the final bottom line there, we've been successful in 127 cases, and those would entail many investigations, more than the 127. And there are other investigations that didn't reveal a case, rather false positive. In each one of them, there was zero transmission to co-workers. And in the context of schools, we are confident. We are in a very good position to manage this outbreak. I have no doubt we're going to see sporadic cases, but we should be able to manage that they wouldn't become clusters or big outbreaks. It's worth mentioning that one case in a school is not automatically an outbreak. There should be an evidence of transmission within the school. So people would be at least one person infected from another person within a school. And those things that the protocols can easily point out. These investigations are done privately. It's paramount in this slide and the next slide that if parents hear that there is a case in a school, that anxiety should not be the driver of their behavior. It's not that everybody in the school needs to be tested or the community to be tested. The definition of close contact, a person who needs to be tested and isolated, is only decided by public health and public health only. We have communicated to the school principals and the officials, and they know their role is not to provide such direction to parents rather to point out to public health who would be calling the parents. And if one example how definition of close contact is a process that's complex and specialized. One of the suspect outbreaks was in one of the 3 hospitals that we have. We had 2 cases, and we asked the occupational health in the hospital to provide the list of potential people who could be close contacts. And their assessment was about 70 on the ward, 25 in the emergency department. Out of the 70 on the ward, and we assess the risk of each individual and what they do, what type of activity, or a group of them at a time if they do the same activity. Out of the 70, we tested 0. So not everybody who got in contact with the case is going to be considered close contact. And now we have the luxury of 2 months lapsing, and none of these people developed disease. So the assessment was conservative, although none of them tested. Out of the 25, we tested 7. Again, there was no further transmission. So from this example, it is very safe statement to reassure the parents. If there is a case in the school, we already covered the investigation. And if they didn't receive a call from public health, that is a very good day. That means the risk was assessed and they don't need to be tested. Similarly, if there is symptoms, a person with symptoms in the school, the next step is to get them assessed by the healthcare provider or assessment center, and not automatically assume that they need to be tested. The first step is to rule out disease. And if we can rule it out as, strep throat positive or allergy, the kid will stay home until they recover and come home. But the rest of the class will continue with no issue. If they need to be tested, they need to be isolated and their family isolated until the results are pending. And again, this is a very conservative approach, rightly so. We don't want to take any risk with the potential person becoming a case and they're still attending schools or in contact with other people. And I would encourage, again, the public, if they happen to see these minutes and hear these words, that spending a couple minutes on our website, couple minutes per day on the school website, they will find many answers to the questions they have, and they can make informed decision about their kids returning to school instead of being driven by anxiety or the social media messaging that could be hit and miss in accuracy. And open to questions as always.
Thank you, Dr. Ayres. So I will open it up for questions from the board.
Mr. Chair.
Sue?
Okay, just how many schools are we looking at? How many in Grey and Bruce counties?
We have 49 schools,
In total.
Madam Mayor.
Okay, thank you.
Somebody else was trying to get in there?
Mitch, it's Al.
Hey, Al.
I want to congratulate Dr. Ayres and his team for this plan. I think from the outset, it looks like it's going to work. I guess where I get concerned is the negativity put forward by some of the unions. And I hope everybody goes into this with a positive attitude. And I think if that's the case, then we can all make it work.
If I may, Mr. Chair, through yourself, I agree that there are different stakeholders around the table that they are trying to do the best for their parties. However, I share the same concern with Mr. Barfoot. We have planned for meetings with staff from schools and through town halls, a series of them, to provide the fact and to provide the information that they need to make decisions. Again, I said it many times that it might be a bit of a statement that repetitive, but this is manageable. And we have proven over the past 5 months that we can manage it, and we have managed it during the lockdown and later in the reopening. And going forward, I see no reason that the compliance from the public, the engagement from the public, and the different organizations around the table would be optimal. And to finish it, I go back to the same concern. I am very concerned if different organizations will push their own agenda to increase the anxiety in the public or in staff in school and parents.
Okay, thank you. Other comments or questions?
Ann Eady.
I am.
Hi, Mitch. I think it's an excellent plan under the circumstances. I think everybody's worked together to do the best they can. And I totally agree. Kids need to get back to school. And as you've said, we have probably the best chance in Grey Bruce with thanks to everybody's efforts, our epidemiology, our numbers, etc. So I'm truly hoping that it will all work out. I think the amount of coordination involved with school boards and staff and it's just unbelievable what you've probably gone through in the last 4 or 5 months trying to coordinate all this. So I think you've landed in a very good place. But I was just wondering, so I think you alluded to the fact that, you know, somebody that just catches a flu or has a cold is also asked to stay home just as a precaution. Is that right?
Until proven it's not COVID, correct. So
Okay.
if we are able to get the test done and the results back within 24 hours, maximum 48 hours, that will be optimal. And that's why it's really important not everybody runs to get a test, because a test that's not needed is going to lengthen the processing time for the test that we are waiting for.
Okay. Yes, I was just thinking, you know, some children just have a lot of allergies or, you know, are just kind of prone. Their immune systems aren't the best, and they catch everything that comes along. So I'm hoping with all the protocols that are in place, kids will be actually healthier, and there won't be the usual thing that runs through a whole class. Even though I hate the idea of them being so cautious and physically distancing, but they will adjust. Kids are very resilient and will adjust, but that's my hope. And then that will make it easier for everybody involved, and children won't have to miss school too much, because it is harder when you have, you know, 4 or 5 kids in your class and they haven't been there for a week or 2 and you have to catch them up. And if that happens on a regular basis, you just don't seem to make the progress which is needed at this time after the absence. So it all sounds good. Congratulations on all your work on this, you and your staff.
Thank you, Councillor. And through you, Chair, indeed, when these all measures in place, the other illness will be much less. And that was evident in March when the shutdown took place and the influenza epidemiology really stopped in its track. It is the better practice, again, to ensure that our protocols are robust. But that doesn't mean that if somebody has allergy, we're going to be excluding them because of the allergy. Rather, the first step, as I mentioned, the healthcare provider would review the situation and provide confirmation that, you know, the kid is not COVID. It's ruled out as COVID, and that would allow them to go back to class even without testing. Mr. Chair, if I may point out, I put this slide here just because of the mask on child. And this picture is from my family. It is very present on the social media, and the request are kids mandated to wear a mask, and the answer is no. It's not the better practice, and it's not even in the guidelines. In any guideline that came from the ministry, the word mandate did not exist. For age grade 4 and up, it's required with many exemptions. And under age 4, it's not required. Again, it's universally encouraged to use However, we know with kids, this picture lasted with a mask maybe a few seconds for the picture. And later, my daughter would, for example, would want to wear a mask for the fun of it. Then suddenly the mask is everywhere in the house other than her face. So it's not realistic to expect kids and to force them to do this. And especially with younger ages, and it's a trauma usually for a kid to start kindergarten, and could be very difficult for the family and the kid. And it would not be appropriate if that kid went to kindergarten and they cannot see that smiley face that can put them at ease. So again, there are many exemptions, and it's a better practice to encourage using it, however, not mandated in schools. And that's the position that we take. We stand by the science in Gray and Bruce. And I reassure the parents that there is no mandate for masks to be used on kids, rather encouragement if possible.
Any other questions or comments for Dr. Era?
But I love the red hair out of Dr. Era.
I'll put it back there.
I just have a bit of a question or scenario or whatever you want to call it, but my thought is with everyone going back to school, I think that anxiety and fear, I think, what I'm hearing from when I talk with teachers is there's a lot of personal fear and anxiety. I mean, they've been out of work for, quite a while. They've got families. So I think there's going to be probably a lot of calls on the public health nurse initially. Maybe, yes, there may be some symptom from COVID, but I think they may be dealing more with a lot of anxiety and just fear, which may come out in physical symptoms. So I just don't know, I just was wondering sort of your preparation for your nurses around that scenario, because that may be more prevalent initially.
Right. So the role of the public health nurse is really coordinating of management of outbreaks or potential outbreaks. If somebody had any symptoms, they will be screened by their family before they get to school, and they will not be sent to school. And there is another screening throughout the school day. And if somebody developed symptoms, they will be isolated. And there is some role for the public health nurse to provide support to the school to execute these actions. However, the nurse would not be there examining the kid. Rather, the kid should be excluded from the school immediately and evaluated by the healthcare provider, their family physician or nurse practitioner outside. So again, the number of nurses that we have for the number of schools that they're servicing and the role they have is actually quite manageable, even if we get multiple kids with symptoms going forward. I'm not sure if that answers the question.
I guess I'm just wondering, are there supports in place? And maybe that's through the school board more so, with your meetings, but are there going to be some supports in place for sort of the angst and fear that staffing may have, the first week or two when they're in building?
I see. Sorry, I was answering more technical nursing work. There is, again, the communication team is arranging for all these pieces of communication going out the town halls. There are different teams in-house that are supporting the public health nurse and supporting the schools. So the nurse's role would be to coordinate providing the information from our different teams to the school, provide direction whenever there is management to any situation. I feel very confident we have everything in place to address those needs when they arise.
Okay, any other comments?
Yeah, Mitch, I have some questions.
Sure, Chris.
Doctor, I realize that this area, because it's inside the school, isn't the jurisdiction of the health unit, would be working conditions, Ministry of Labor. But with regard to ventilation, the province did provide money for enhanced ventilation in our schools. So we have 49 of them. Is there any information out there on what the school boards have done to evaluate the ventilation in the classrooms to ensure that there's proper air exchange in the multiple classrooms that we have in Bruce Grey?
So I know that different schools at different stages in looking into these issues related to ventilation. It's worth mentioning, if I may, Mr. Chair, just provide some short background about ventilation and COVID, just to provide the facts about different opinions out there or things circulating on the social media. COVID does not move in the ventilation system from class to class. This is a question that many people think it does. Legionella, for example, does live in the air conditioning system. COVID is not the same. And if there is a shared ventilation system between different rooms, that's not a risk for transmission. There could be some benefit if the circulating air is increased. We know that there's a huge difference in risk of transmission between indoors and outdoors. And the main factor there, the only factor, is the ability to dilute the droplets or the particles that would be held in the air around a person in outdoors more than indoors. So there is benefit in increasing ventilation. However, it's not really one of the main level of controls in controlling the transmission and the hierarchy of control. If we ensure the 2 meters distance, the high frequency of disinfection and hand washing and using masks and all the other measures, ventilation will be an added benefit, but it's not 40% change in the outcome. I don't know the exact numbers. I don't think there are studies how much there is efficacy clearly to increasing ventilation in what way. So there is benefit to it. I realize there is investment, a good investment in it, and schools, some of them are working on it, others have not. I can provide a summary of percentage of schools and how far they've gone next time we meet. However, all in all, it's really one added layer of protection. And if it's there, that's great. If not, it might not really change the outcome of the management.
Well, we do know, though, that the 2 meters will not be in practice in the classrooms between students, teachers.
Again, depending on the scenario, if people are walking through the corridor and it's busy, the 2 meters is not there. However, the time frame for that interaction is minimal.
Right, but any classroom with over 15 students, there will be some students below the 2 meter threshold.
My understanding from the bigger schools that have high class numbers, the highest that we're talking about is 30, 34, I believe. They have been invested so much effort to reduce the number of people in a class. And there are many variables here to consider. Is the age of the kids, for example. If you have 30 high school kids, you can give them instruction and information, and in general, they're reliable in executing them. If it is a 5-6-year-old kid, it's extremely difficult to control the risk of 30. So there are many considerations in it. However, all in all, I feel confident that the schools have invested into robust plans, the ones that we have seen, and from the discussion and the questions that we had. Everybody around the table want to meet the expectations and exceed it, which is reassuring as always.
But a class of 30, it won't even be a 1 meter separation, which in my mind would make the whole thing about ventilation all the more important.
Mayor Peabody, like if you look at the 2 meters, there's nothing magic about the number 2. It's not binary, 2.5, somebody's going to be very safe, and the 1.5 meters, they're going to be infected. The World Health Organization recommends 1 meter of distancing because they designed their recommendation for different cultures, different built environment. The built environment we have in North America tends to have more space to anything we do. And that's why the 2 meters is actually practical. If it's not met in every single minute during the school day, again, it's not, means it's binary, and we failed There are many other measures. The screening before a kid comes to school is extremely important, because you can have people hugging each other in school. If none of them is a case, at the end of the day, there is no transmission. I'm exaggerating with the hugging, but I mean, if it's 1 meter, but there's enough screening and there's enough hand washing and there's enough disinfection and wearing masks during those times, it is, again, manageable. And you go back to the slide where there are stories of success when you see a country like Sweden or Denmark, the entire country opening classes for a period of time, months, not weeks, and with 0 cases. The notion that everybody's going to be infected if there is a case is not a fact. Ventilation, again, is a very good point, and it's a good investment in our schools for many reasons, for health and for prevention of disease. But if it's not there today, that doesn't mean that our plan going forward is not manageable and could be successful.
Okay. Second question I would be the busing, and once again, with the busing situation, I know it's not possible to hire more bus drivers. We can't find enough of them as it is, but there won't be that separation on the buses either. The kids will be sitting right beside each other. 44 kids on a bus would be, I think, a concern, because you throw out those. You did mention that the separation is the gold standard of our protection measures with the COVID, but then we're putting the kids 44 to a bus in some cases. Hopefully, some of those buses will be a lot fewer kids, but that is a concern about the busing.
Through the chair, definitely I share the same concern. The school bus environment is not as controlled as the class environment, and the space in it is limited. However, all in all, the measures that are implemented, again, the screening to start with before a kid comes to school and the screening during the school day, would ensure that people with symptoms are not going to be on that bus. And we know that the disease can be asymptomatic. However, we also know people who are asymptomatic are not the driver of the outbreak. That is, for many reasons. 2 of them is their ability to infect is lower, and their disease infectivity window of time is actually shorter. So they're not the driver of the outbreak. And if you have all the screening that happens, all the cleaning between cohorts who use the bus, it will be optimal to have 1 kid in 1 seat. And that could be very well done if many people opt to drop off and pick up their kids in their private vehicle. We can't really depend on this, but if it happens, that will be great. If not, you might find 2 kids in 1 seat. But you can appreciate that if there is a kid sitting on a seat and there is somebody beside them and they are infectious, the most they can do, if they're not reliable, if they're younger age and just want to touch everybody around them, they can touch the person beside them, the person in front of them, and the person behind them. So again, it's not a scenario where the virus is going to be circulating in the whole bus and infecting everybody. The ventilation in a bus is not optimal. Some of the newer buses are better. But all in all, if you put all the measures in place, it is still acceptable level of management of the outbreak. And again, if it wasn't, we would have recommended against it. And if I can go back to the same slide of successful examples, there are countries that didn't have a case in a school. In Grey and Bruce, we do have epidemiology that is better than these countries, and we do have the relationship between stakeholders and the commitment from the public, commitment from the local government, commitment from the provincial government, and from the organizations, the schools themselves. So you put it all together. Again, I feel confident. We have many resources to put in place, and we have been putting them in place to ensure safe reopening for our kids.
Okay, thank you. No, I certainly agree with the other part of your presentation. The health unit did a great job in controlling the 127 cases not spreading. And I do believe that that if there are any cases in the school, your team will handle it in the amazing way that they've done. But just the overall plan. With those 2 items I mentioned, I do have a concern, but given our excellent epidemiology in Grey Bruce, parents should not be concerned with the return to school. Although I do think in other areas where perhaps they had trouble with the outbreak, with the COVID in the province, with those 2 issues with the ventilation and the busing, they may encounter some difficulties. But given our epidemiology and our health units efforts, it is the conditions are there for a safe return to school.
Through the chair, thank you for the remarks, and I agree that the majority of parents should not be concerned. Some families might have kids with vulnerable conditions, medical conditions that would make their kids predisposed to severe disease or complications, or they might have household members, older individual in the household that might suffer of the disease. For these families, they are strongly encouraged to evaluate the situation with their healthcare provider and see if the return of their kid is something that they can make the decision on, positive or negative. At the end of the day, in general, the risk is quite acceptable and the situation is controlled. But for these families, they might not want to have any risk whatsoever for a period of time. And this decision is really not an easy decision for parents. It's not the normal year. This happens once every 100 years. The last time it happened 102 years ago with the pandemic, the Spanish flu. So those decisions are complex, they're difficult, and they're not one-time decision, because a family needs to reevaluate the situation every week, every 2 weeks, and decide, if I didn't send my kid to school from day one, should I send them after a week or 2 or 3? And to that end, our role is to provide the parents and the schools with accurate information and timely information as we go forward.
Good, thank you, Dr. Era. Any other comments?
Mr. Chairman, Buck here.
Hey, Buck.
So one thing, my young daughter is very upset that when she goes back to school, she won't be able to hug her friends, but that's life. On the issue of ventilation, I have one child that will be attending school in London, and it appears that at least in London, they're recommending that they go outside as much as possible. So many classes will actually be held outdoors. And very frequent breaks while the weather is good. Is that the same recommendation in Grey Bruce, and are the boards in Grey Bruce planning to take advantage of outdoor opportunities?
Thank you for the question. It brings a very important point. Yes, the answer is yes. It's part of the recommendation, and there are several schools who have their entire classes planned outdoors as long as the weather and the conditions allow. And it was after the protest for Black Lives Matters that the evidence have been very clear that there is significant change in the transmission indoors versus outdoors. And it is a recommendation to have activities outdoors whenever possible. That is the same principles that are used in London are used here as well. There are so many layers and complexity to the plan. So, I appreciate that you brought the point up. There are many other recommendations are in place, and I think if we're going to go through all of them, it's going to take hours.
Okay. Other questions? Okay. Hearing none, do I have a mover and seconder to receive the year's report?
Edie?
Edie? Seconder?
Patterson.
Patterson? Okay. Anyone opposed to receiving that report? Hearing none, I will consider that approved. Okay, down to corporate services. We have the May and June financial reports. Matthew, I'm going to turn that over to you.
Thank you, Mr. Chair. We've given you 2 months, actually, May and June's of financial statements along with a report. So that actually catches us up so that our reporting will not remain at this iterative cycle. Appreciate the patience of the board so that we got ourselves caught up. The other piece to this, we're ahead on our budget year to date, mostly because we've shut a number of services that we normally would be spending money on down because of the response to COVID. And as we move forward, I think that some of the actions that we have taken to hire will begin to eat away significantly at our over budget, our surplus position. Over budget may mean that we're actually in a deficit. We're not, we're in a surplus. The other piece is there's a report at the end that talks about the both time, overtime and time spent on COVID, and that brings us to the middle of August. I submit that, and if there's any questions in regards to it.
Sorry, what was that last part, Matthew? I didn't catch that.
The overtime, so we have a total time graph and a portion of that relates to both overtime that we have experienced, which is all COVID related, and the actual time that we as a health unit have spent on COVID. There's a bit of a bell curve, so you can see those 2 different colors, and we continue to experience a little bit of overtime and also a little bit of
Sorry, can you put up the graph on the screen?
So it's just the report.
Thank you. Okay.
Personally, I thought there'd be more overtime, so it's interesting to see that graph, and I suspect it will go down a little bit more once we keep going through this.
Yeah, we do expect that overtime will be virtually, you'll never quite eliminate all of it given some of the bits that are going on as we see it now, but it'll be substantially very minimal. And wave 2 will be potential. No, that's what you're looking for.
So from sorry, I realize it's corporate and money, but really correlates to the functions that we have. So you can see the orange bill shaped curve, and the blue one is the sorry.
Sorry, I'm talking over you. Go ahead.
No, that's all right. So that they are consistent with the functions that we have going forward with the planning with schools, and it really depends on the epidemiology. Those numbers might go up, might stay the same, might continue to go down. So there is no way to know ahead of time how those would play out. Sorry, Matt, interrupted your point.
I think item 2 is very important, obviously, as well, with regards to the funding from the province. That is good news. I know we have begun budget deliberations, not deliberations, but information sessions, getting prepared for the 2021 budget. So this, from a county perspective, is good news, and hopefully item 8.2 that the province will see fit moving forward, that the jobs that the public health has done across the province is well worth the funding. So that is good news for a couple of years at the very least. So any other questions or comments for the corporate services reports?
Mr. Chair,
yes.
If I may. So there's, I did want to talk a little bit more about the funding, and thank you for bringing up number 2 of that. I did have perhaps a few other comments about the nurses that is coming up. So we have, sure, you can put that up. So the memo on the funding updates, I think, is fairly straightforward, and it is really good news. I think that is an indication of what the province thinks of our jobs, what we've done with the pandemic so far. But there's also the second piece to that is the nursing funding. We have 6 additional nurses, and this is like hot off the press. We just received a further update from the ministry that actually expands that now from 6 to 9. And that just came from Elizabeth Walker. So that was, I just wanted to bring that further so that well, we have hired the 6, we now have 3 more to go get. Again, falls within the same, so that's a continuing of a 2-year commitment to both of those, to all of those nurses.
Okay, any questions or comments for the corporate service? Okay,
Just for information.
Sorry, Matt, did you have something else?
Well, Sue's just pointing out there was the last staffing update memo. That was really just for information to you. So if there was any additional questions or, you know, who were we hiring and what is open, that's available to the board to ask.
And Mr. Chair, through you, I would like to add a couple points on this last, if you can keep it up there, Sue. So you can see from this slide there, or this screen, there have been many hires based on the need for the emergency. Number 2 in the list, 1 contract epidemiologist. We have contracted an epidemiologist around after the first wave, actually, and it has been about 2-3 days part-time, has been very sufficient to provide us with all the epidemiology need, despite the fact that we are in the middle of a pandemic management and epidemiology is key. And this really reflects the decision that we made early in the year to reduce the hours of epidemiology service that was hired permanently. And we managed through the first wave optimally with the expertise in-house that we have with epidemiology, whether it's through a few staff who have epidemiology expertise, myself, the associate, and the extra need that we are projecting for the times to come and for the past few months has been fulfilled through a contract, which is optimal from point of view of assessing the decisions that we made early in the year. Similarly, we hired 2 managers, and in the hiring of the managers, we went with basically management criteria, not necessary technical expertise to be a nurse background or public health background. And it has been very successful in complementing the team that we have these skills that we acquired. Similarly with the other hiring, there is a success story with each one of them, and in the interest of time, I can answer questions if needed, and I'll turn it back to the motion, I presume. Thank you. It's on mute. Mr. Chair, you might be on mute.
I was on mute. Sorry, I have my lawn being cut right now, so I wanted to try to keep it as quiet as I could. So do I have a mover and seconder to move the corporate services report as presented?
Buck here, so moved.
Thanks, Buck. Seconder?
Millen.
Millen? Anyone opposed to receiving and approving the corporate services report as presented? Hearing none, I will consider that approved. Okay, so next item is to go in camera. So I need a mover and seconder to go into camera for advice that is subject to solicitor client privilege. 1 item and matters but an identifiable individuals. There are 3 items. Do I have a mover and seconder to go into closed?
Edie.
Thanks, Ann. Seconder? Buck?
Sure, I'll second that.
Anyone opposed to go into closed? Hearing none, deal with your update, Al, and then we'll go into the staff retirement presentation, if that's okay with the board. I'm hearing no.
I'm sorry, what was Al's update? Sorry, I was speaking with Dr. Era. What was his addition?
It's been partially discussed, but I'd like Dr. Era to comment on the healthcare modernization, really where we're at now on it.
So
Thank
Sue,
you.
if we could call that 10.1A before we go into the staff presentation.
Sure, that's exactly where I put it.
Okay, thank you.
Thanks.
Always one step ahead of me.
Chair,
Yes.
I'll move to rise out of in camera.
Did we do, did we do a motion?
Well, to be honest with you folks, we just went through an investigation where in fact you do not have to do that. You can simply, after the last item is discussed and direction was given and closed, you can, it's the call the chair to say rise from enclosed. So that is just hot off the press, right, Ann and Chris?
Mayor Edie, you're on mute.
Sorry, and give your report generally on the in-camera.
So yeah, so right now so we've risen, I will rise and report. So under 9.1, we have given direction to staff, and under 9.2, we've also given direction to staff. So that is the update from in closed session. Okay, next item of business is 10.1, the board remuneration report. You've seen the report. Any questions or comments? I guess my opinion is we're right in the middle from what I've seen, and is the board looking for any further changes to remuneration as presented today?
I was just wondering, so a Zoom meeting is considered half a day then? Whereas if you're doing traveling time, maybe you go over. So half a day is 3 hours, right? Or and a full day is anything over 3 hours?
So I'm going to take a stab at it and turn it to Matt if I need to be corrected. The meeting itself is 2 hours. However, the preparation for it cannot be less than 2 hours to start with. So that really brings us to the full day in almost every meeting we have, regardless of transportation.
Okay, thank you. I was just wondering.
Any other questions or comments? Okay, moving on to 10.1A. Dr. Era, we just made that addition through Al.
Oh, sorry, the A, I looked at the one in front of me. So the modernization of public health, the 2019 year ended with the agreement from all stakeholders around the table to go back to consultation, and the Ministry of Health requested from Health Unit to provide input in the optimal way to go forward with modernization. We had our submission in February and March. Then after that, the consultation was put on hold completely during the emergency. It's worth mentioning, although the consultation has been put on hold, many structures related to regionalizations has been put in place during the emergency. One example is communication about the functions of public health we have been requested as a health unit to provide it to Ontario Health, which is a regional structure. And we have been providing that information. Also, there has been communication in the opposite direction where we're receiving memos and requirement to collaborate with different parts of the system or to do functions. Sometimes that is public health, others it's not. Regardless of pausing the modernization consultation, there has been many things that put in place that makes a public health function in a regional way.
So stay tuned, I guess, Al.
It is worth mentioning that in every discussion about regionalization that happened in the past 15 years, AMO has been instrumental in conveying the appropriate message for the local need to keep the connection between public health and the municipality as the main driver of the function of health units or public health. And during other years, there was always a Como and Alpha meeting, and AMO was involved. During the emergency, these meetings have been paused or put into a Zoom format that could be less than optimal in eliciting support from AMO to ensure any progression of regionalization is balanced with municipal need and public health municipal relationship being intact. And to that end, it's really important that our board is aware of this, and other municipal leaders are aware that public health would require that or the preservation of relationship between public health and municipality might require advocacy during these times and going forward as well.
Okay.
So I was just wondering, is now the time to discuss? I think we need to be proactive on that advocacy. And is there anything else we can do at this time to be proactive on that? Or we can discuss at the next meeting. It's just fine, but I really think we need to be proactive on that.
And to that point, Dr. Era, for the agendas moving forward, if we can maybe make that an agenda item just for update on a monthly basis, I think that would be good. Is the board okay with that?
Yeah, great idea. Yeah.
Certainly. And I, through your chair, I hear that there is a need for summary or providing a picture of where we are with modernization and what type of advocacy or venues of advocacy might be considered by the board. So for the next meeting, I can bring these two items or these two sub-items for board considering giving us direction, and we'll provide this next meeting, sorry.
Thank you, Doctor. And then Nan, that can address your issue if we need to have more advocacy, and we can do that via board resolutions and send it out to the appropriate agencies.
Thank you.
Okay, next up, we have a staff retirement presentation. And I think you're going to bring our guests in, Dr. Era.
Yes, sir. Yes, Mr. Chair. So with a very, very saddened heart, and I really don't use these words loosely, I presenting Marilyn Lemon, one of the most wonderful, most effective team players that have been in this organization way before I have been by definition. And she has seen different organizations, whether it's Gray Bruce on sound or Gray and Bruce or different format of this organization. I cannot remember an incident or a situation or a task that Marilyn has been involved in without being praised by everybody around the table. I've always catch myself smiling when I chat with Marilyn or remember what we chatted about. And it is extremely with sad heart to share with you that she's decided to go on retirement, well-deserved, well-achieved retirement with great reputation and memories, and we will miss you. We will really miss you.
Thank you.
On behalf of the board and the organization.
Thank you.
And I would have given Marilyn a hug, other than it's COVID and it will be virtual.
Hugs in the air.
If you can.
Can I
Yes, absolutely.
Open the
I
floor.
just put together a couple of words at about 3:45 this morning. I woke up and they were in my head, so I thought I've got to go write them down right now. But that's totally me. So I wanted to thank you for inviting me to your meeting today for this presentation. As you know, I have been a nurse for a long time. This year will be 40 years since I graduated as a nurse. The early part of my career was spent as an emerge and trauma unit nurse, mostly at Victoria Hospital in London, Ontario, my hometown. I have also worked casual as a nurse practitioner in the primary healthcare setting after obtaining the extended class license a number of years ago. But the bulk of my career has obviously been here at the health unit as a public health nurse. I have been with public health for 31 years now. And when I look back on those years and all of the things that happen when you work somewhere for over 3 decades, the biggest thing I have learned is not about being a public health nurse, but how to work with people, how to get along. Be productive and get the job done. For at the end of the day, that is what is important. I want to walk out of here every day knowing that I did my job and I did it as well as I could. The best way I have found to do that is to respect each other, look for the individual strength in who you are working with, and just get along. I want to thank the Board of Health and you, Ian, and management for having faith in me to work here for all these years. And as a public health nurse, I feel very fortunate that I have worked here for this length of time. So thank you again.
So Marilyn, on behalf of the board and all the residents of Grey Bruce, I truly want to thank you for what you have done for us and our communities. It's folks like you that put your daily lives on the line for us, whether it's serving the public from the health unit or being at Victoria Hospital or wherever it is that you've worked in the past. So I just want to thank you, and it's truly nice to have individuals like you working for the health unit, and we wish you the very, very best in whatever endeavors you're looking for, and I know you're always welcome to come back. So thank you very much.
Thank you very much.
Okay, so before we let everybody go, there's one other individual I would like to recognize today, and that's Lori Laporte. Lori, are you, unless there's new news that I haven't heard, that this might in fact be your last meeting today, Lori?
Yes, it very well could be.
Okay, well, if it is, I just want to let you know that we did support you for another term. I don't know what's gone on or what's happened, but I thoroughly want to thank you for getting to know you since 2014 and the time and effort you've given to this board and as a public representative. It's truly been remarkable working with you, and you're an honest, good person that has brought a lot to the board and to the residents of Grey Bruce. So for that, I thank you. And if you are in fact not at our next meeting, I just want to wish you the best and welcome you back whenever that time may be. So thank you very much.
Well, thank you. I've enjoyed my time. I've learned lots, and I wish everybody the best going forward. So thank you.
Okay, thanks, Lori. Okay, if there is nothing else today, folks, if I have a mover and seconder for adjournment, we will meet again September the 25th at 10 a.m. Mover and seconder.
Edie.
Edie.
Buck, I'll second.
Seconder. Okay, thank you, folks. We are now adjourned. All the best.